This is a video demonstration of double phase augmentation urethroplasty for bulbar urethral strictures, a dorsal versus a ventral approach. Coming to the surgical technique and its implications, the primary decision when to consider a dorsal or a ventral approach is based on the intraoperative decision to identify the landmark bulbospongiosus muscle and its relation to the distal extent of the bulbar urethral stricture. If a catheter is passed through the urethra and the distal end of the bulbar urethral stricture is distal to the above landmark, a dorsal approach should be planned. However, if the distal end of the bulbar urethral stricture is proximal to the above landmark and this corpus spongiosum width is more than 15 mm, then a ventral approach can also be considered. Other technical parameters to be considered were when to consider an inlay augmentation. Following a ventral or a dorsal urethrotomy, the decision to consider an inlay graft augmentation is very crucial. Two factors needed to be considered are urethral plate width less than 6 mm, length of the narrow urethral plate. If the stricture length with narrow urethral plate is less than 2 cm, associated with or without focal spongiofibrosis, a stricturectomy with inlay augmentation can be considered. However, if the stricture length with narrow urethral plate is more than 2 cm or there is diffuse spongiofibrosis, then a stricturotomy with an inlay augmentation should be planned. Following an inlay and onlay augmentation, during double phase augmentation urethroplasty, another important observation is to avoid overlapping graft suture lines both distally and proximally. This maneuver reduces the risk of distal and proximal anastomotic rings. This is a short video clip of dorsal approach of double phase augmentation urethroplasty. On imaging, there was a bulbar urethral stricture, and on urethroscopy, it confirms a narrow urethral lumen. Midline perineal incision was given, layers were deepened to identify the landmark distal extent of the bulbospongiosus muscle. Relation to the stricture was found distal to this landmark, henceforth a dorsal approach was planned. One side urethral mobilization was performed across the midline. A dorsal urethrotomy incision was given, extending it distally and proximally till the normal urethral mucosa was identified. A dorsal onlay buccal mucosa graft was placed and fixed. Urethral plate was inspected and the width was less than 6 mm and the length of the stricture with spongiofibrosis was less than 2 cm. So a stricturectomy was performed, a ventral inlay BMG patch was placed and fixed. Following augmentation, overlapping of graft suture lines were avoided both distally and proximally. Catheter was placed and the urethra closed. This was the compared follow-up voiding study at 3 months. This is a video clip demonstration of ventral approach of double phase augmentation urethroplasty. A similar case of bulbar urethral stricture with a narrow segment of urethra noted on urethroscopy. After a perineal incision, the landmark bulbospongiosus muscle was identified. Here the distal end of the stricture was proximal to the above said landmark. The corpus spongiosum width was 18 mm. In this scenario, we opted for a ventral approach. Ventral urethrotomy incision was given. The incision was extended proximally and distally till the normal urethral lumen was identified. The urethral plate was inspected. A dorsal urethrotomy incision was given at the level of the narrow urethral plate, which was less than 6 mm. As the length of the stricture segment with narrow urethral plate was more than 2 cm, a stricturotomy was performed Dorsal inlay buccal mucosal graft was placed and fixed. Overlapping graft suture lines were avoided. Ventral onlay buccal mucosal graft repair was performed. Urethral lumen was sutured over a catheter. The spongioplasty was performed. Perineal skin was approximated. This was the outcome on imaging at 3 months. I would conclude that double phase augmentation urethroplasty by dorsal approach or ventral approach should be decided intraoperatively based on the extent of the stricture in relation to the bulbospongiosus muscle, the corpus spongiosum width, and the degree of spongiofibrosis. Dorsal approach is a versatile technique and can be considered in all circumstances. Ventral approach, though technically easy, should be performed selectively in patients with proximal bulbar urethral strictures. Thank you.